Good morning, I am Dr. Bhavna from the Department of Cardiac Anesthesia. Today we are going to talk about pulmonary embolism and the recent changes in nomenclature brought about by 2026 AHA guideline. So, pulmonary embolism is the obstruction of one or more pulmonary artery by thrombotic or non-thrombotic material, and this thrombotic material or the emboli, that could be either a thrombus which is more than 90% from the DVT, or it could be a fat emboli, air embolism, amniotic fluid embolism, or a septic embolism. Coming to the epidemiology of pulmonary embolism, it is the third most common cardiovascular disease after myocardial infarction and stroke. The incidence increases with increasing age, and 60 to 70% of the patients having pulmonary embolism have associated deep venous thrombosis. And if pulmonary embolism is untreated, the mortality is around 30%, and prompt diagnosis and treatment will reduce it to less than 10%. Coming to the risk factors, the most commonly identified risk factors comes together as a Virchow's triad, which comprises venous stasis, endothelial injury, and hypocoagulability. Venous stasis is because of prolonged immobilization, long distance travel, heart failure or stroke, or anything leading to endothelial injury, could be surgery, trauma, indwelling central venous catheter, etc. And the conditions leading to hypocoagulability could be active malignancy, pregnancy and postpartum state, estrogen supplement, inherited thrombophilias, or any antiphospholipid syndrome. And also there are additional risk factors, which is the history of previous venous thromboembolism, obesity, increasing age, smoking, and chronic inflammatory diseases. Coming to the pathophysiology of acute embolism, pulmonary embolism, it occurs when the blood clot enters the pulmonary circulation, and this large emboli obstructs the main pulmonary artery, causing saddle embolus with deleterious cardiovascular consequences. Along with the cardiovascular consequences, we can also see some respiratory consequences as well. Whenever the emboli sizes are small, it blocks the peripheral artery, causing pulmonary infarction, which is manifested as intraalveolar hemorrhage. So this pulmonary embolism causes impaired gas exchange due to obstruction of the pulmonary vascular bed, leading to respiratory consequences, which is the mismatch in the ventilation to perfusion ratio. And the pulmonary capillary blood flow also decreases, leading to dead space ventilation and hypoxemia. Along with this, there is release of inflammatory markers like serotonin, which causes vasospasm and decreases the flow of blood into the unaffected regions of the lung. And this accumulation of inflammatory markers alter the lung surfactant and stimulates respiratory drive, resulting in hypocapnia and respiratory alkalosis. So coming to the hemodynamic cascade that follows pulmonary embolism, there is mechanical obstruction of the pulmonary artery, which leads to increase in pulmonary vascular resistance. Now the right ventricle, which is so used to pumping against the low resistance circuit, has to pump against increased resistance, leading to increase in the right ventricular afterload, which eventually leads to RV dilatation and ischemia, and the output of the right ventricle is significantly reduced. And since we already know that the left ventricular preload is the right ventricular output, so if RV output is reduced, our left ventricular preload is reduced, which eventually leads to reduction in cardiac output. And this is manifested as hypotension, and this hypotension eventually leads to reduction in coronary perfusion pressure, decrease in coronary perfusion, more ischemia of the right ventricle, RV output falls, and then this hypotension deepens, and this is a spiral which is self-propagating. So we need to break this spiral, and if it is not broken, then the patient with massive pulmonary embolism can deteriorate very quickly. Also, the respiratory consequence of gas exchange, there is ventilation perfusion mismatch and increased alveolar dead space, right to left shunt, which leads to hypocapnia and alkalosis, like I have told previously. So this is the increase in vascular resistance of the pulmonary vascular bed due to mechanical obstruction by the thrombus or hypoxic ventilation increases the PA pressure. And if the embolic pressure increases by more than 30 to 50%, sometimes it can increase by 30 to 50%, and the pulmonary vascular resistance increases the right ventricular afterload, which impedes right ventricular outflow and causes right ventricular dilatation and flattening or bowing of the interventricular septum. Sometimes right bundle branch block also develops, which increases the desynchronization of the ventricle, and this decreased right ventricular outflow and concomitant right ventricular dilatation reduces the LV filling, compromising cardiac output. This image shows whatever I have discussed before. So the clinical presentation of pulmonary embolism is non-specific by nature. The most common symptoms that we see is pleuritic chest pain and dyspnea, and the less common things that we see are hemoptysis, syncope and shock. And syncope and shock are uncommon, but they carry disproportionate prognostic weight. So the things that we have to deliberately look for if we are seeking a patient, if we are suspecting a pulmonary embolism, is tachycardia, tachypnea and hypoxemia, elevated JVP, and if there is any swelling in the limb suggestive of deep venous thrombosis. So very less patients, like less than 10% of the patients who are investigated for pulmonary embolism turn out to have it. That's why undergoing the full length of tests like CTPA for every patient is not required. That is why we do pre-test probability. Like there are two different scores that we can use, like Wells score or revised Geneva score, in the patient to see if we need to go through with all the investigations to assess for pulmonary embolism. So Wells test comprises of clinical signs of DVT, it is scored, and clinical signs of DVT, pulmonary embolism more likely than an alternate diagnosis, heart rate is more than 100, if there is immobilization history, previous DVT, hemoptysis or history of cancer, and if it is standard, like low risk is less than 2, moderate is 2 to 6 and high is more than 6. So we need to do this. And for Geneva, revised Geneva score, there is age, which is more than 65 years, previous history of DVT or pulmonary embolism, surgery under general anesthesia, history of limb fracture within 1 month, any active cancer, unilateral lower limb pain, hemoptysis, and heart rate 95, more than 95, or pain or DVT on palpation. So this is like graded as 0 to 1 for low, intermediate is 2 to 4 and high is 5 to 7. So if the Wells score, pulmonary embolism is unlikely if it is less than or equal to 4, and pulmonary embolism is likely if it is more than 4. So that is when we undergo all the other tests. So now ruling in and ruling out criteria for pulmonary embolism. If the age is less than 50 years, the oxygen saturation is more than 95%, there is no history of estrogen use, and there is no unilateral leg swelling, heart rate is less than 100, no hemoptysis, no prior history of DVT or pulmonary embolism, and there is no surgery or trauma requiring hospitalization within the past 4 weeks. If all 8 are present, then the probability of pulmonary embolism is low enough that no further testing, including D-dimer, is indicated. So D-dimer, it can be done in 3 ways: conventional way, age adjusted ways, and according to the year's algorithm. Conventional way, there is a fixed cutoff which is typically 500 micrograms per liter. It is highly sensitive, but it has poor specificity, which fails in like 10% of patients over 80 years. And also age adjusted is when we multiply age into 10 microgram per liter for patient more than 40 years. And here, if D-dimer does not exceed the chosen threshold, then pulmonary embolism is unlikely, and if clinical pretest is low or intermediate, then pulmonary embolism is unlikely. So coming to the diagnostic algorithm, if there are signs and symptoms suggestive of pulmonary embolism, we have to do the pretest like the Wells and the Geneva, and after that if we have to assess if the patient is hemodynamically stable or hemodynamically unstable. If the patient is hemodynamically unstable, we do not have time to do the D-dimer. So bedside echo can be done to look for RV strain and support and start the empirical treatment. So if the patient is hemodynamically unstable and patient can tolerate going to the CT for CTPA, then CTPA can be done. Otherwise, we'll have to start treatment according to clinical grounds. And if the patient is hemodynamically stable and there is only low to intermediate probability, then we'll have to rule out criteria is done, and if it is negative, then no testing is required. After that, we use the D-dimer according to age adjusted a year's threshold. If it is below the threshold, then pulmonary embolism excluded, and if it is above the threshold, then we'll have to go for imaging. And if there is high probability, that is more than 50%, then we have to go straight to imaging. There are other tests that can be done, but which only helps us to prognosticate the patient, but it does not help us a lot in diagnosis. The other tests that can be done are ECG, which shows tachycardia with non-specific STT changes, and other S1, Q3 and T3 with RV strain pattern and new incomplete RBBB block. They are very classical signs of pulmonary embolism, but it is not commonly seen. In the chest X-ray, we can see normal or non-specific chest X-ray can be there. There can be Hampton's hump or Westermarck sign, but these are like classical signs which are not usually seen. In the arterial blood gas, we can find widened arterial alveolar gradient. There can be hypocapnia and respiratory alkalosis. There can be unexplained hypoxemia with a normal chest X-ray. This should raise suspicion for pulmonary embolism. And we can also do troponin, BNP, pro-BNP and lactate. Lactate is a perfusion marker. It is not a pulmonary embolism marker. So, coming to echocardiography, it is not indicated to diagnose pulmonary embolism, but if the patient is unstable, then we use echocardiography to see if the function of the right ventricle. So, to do this, we assess few parameters like the RV end diastolic diameter, RV and LV end diastolic diameter ratio. We assess the TAPSE to see the function of the right ventricle, and we see tricuspid regurgitant velocity as well. So now there are like pulmonary embolism has been classified, the risk of pulmonary embolism has been classified. This is like in 2026 we have a new risk stratification classification. So according to 2026 classification, there are like three: A, B, C, D and E, and there are also respiratory variants. So A is subclinical, incidental or asymptomatic, and B is symptomatic with low severity score, and C is symptomatic with elevated severity score. D is incipient cardiopulmonary failure. Patient is risk of failure but has blood pressure is normal. So basically it is a case where there is normotension but the patient has shock. And E is cardiopulmonary failure, where there is persistent hypotension, refractory shock or arrest. So A, B, C, D, E, they are subcategorized into A1 and A2, B1, B2, C1, C2, C3, D1, D2, E1 and E2. So A1, where subsegmental, single or multiple lung segments are involved, and A2 segmental or more proximal. B is symptomatic with low clinical severity index with subsegmental, or B2 is non-subsegmental. And C is symptomatic with elevated clinical severity score, C1 with normal RV and normal biomarkers, C2 normal RV or more than one abnormal biomarker, C3 is abnormal RV function and more than one abnormal biomarker. So D is incipient cardiopulmonary failure, as I said before, where D1 there is transient hypotension, where D2 hypotension is not there but patient is in a state of shock. E is cardiopulmonary failure, where there is recurrent or persistent hypotension and cardiogenic shock in E1, and it is refractory cardiogenic shock or cardiac arrest. So there are respiratory modifiers which categorize category C, D and E. So the respiratory modifier for category C is oxygen saturation less than 90% or respiratory rate more than 30 or a requirement of supplemental oxygen. And the respiratory modifier for category D is requirement for more than 6 liters of oxygen via nasal cannula or use of non-rebreather mask. And for the E, the respiratory criteria is hypoxic respiratory failure or ventilatory failure requiring non-invasive or invasive positive pressure ventilation. So coming to biomarkers and RV imaging for risk stratification. In acute pulmonary embolism, an elevated severity score but without hypotension or shock, which is category C, we have to measure at least one cardiac biomarker, which is either troponin or BNP. The purpose of stratification is short-term complication and mortality. It is not for diagnosis, like I said before. In category C and D, RV imaging is recommended for short-term risk stratification, and the parameters that are to be imaged has been discussed before. Here, echocardiography is preferred over CT for risk stratification, and point of care ultrasound has shown acceptable accuracy for assessing RV dysfunction in critically ill patient, and this can also substitute the formal echo if the echo is unavailable. So coming to the hemodynamic assessment of the patient, like the normotensive shock, that is the criteria D2. The normotensive shock, isolated hypoperfusion, this is a condition where there is isolated hypoperfusion without hypotension. That is, like there is hypoperfusion evidenced by increasing lactate, but the patient's blood pressure seems to be normal. So this is the further, like the same risk stratification again. And the new thing that has been added to the 2026 guideline is the pulmonary embolism response team. The possible members of this team includes emergency medicine, cardiology, hematology, intervention radiology, vascular surgery, critical care pulmonary, critical care vascular medicine, intervention cardiology, cardiothoracic surgery, pharmacy, nursing. They have suggested making a team so that the management and care of the patient with pulmonary embolism is rapid and the response is very immediate. So the initial management of based on categories is like the patient whom we have categorized into category A, which is subclinical, we initiate direct oral anticoagulants and the patient is treated as an outpatient basis. With patients with category B, that is low severity, we initiate the direct oral anticoagulant, and the plan of management here is either early discharge or outpatient based on the severity. And C is elevated severity. Here we initiate low molecular weight heparin and we assess more than one cardiac biomarkers, lactate and RV imaging by echo or CT, and we hospitalize the patient in a monitored bed but not in ICU. And in D, where there is incipient failure, we initiate low molecular weight heparin. We assess lactate to see whether the patient has normotension with hypoperfusion. We do the RV imaging, we evaluate for normotensive shock, and the patient is admitted in ICU for intermediate care. And the category E, where the patient is in cardiopulmonary failure, we initiate low molecular weight heparin and unfractionated heparin, and we assess for lactate and RV imaging, and this patient is admitted in the ICU. So as I've already discussed who is discharged home, category A and category B, according to category A will go home, category B according to severity can be discharged, category C will be admitted in monitored bed, and category D and E will require ICU. So anticoagulation, as we have said before, we start low molecular weight heparin and direct acting oral anticoagulants on these patients, but should we monitor the anticoagulation? And that is like the monitoring is not absolutely necessary. In acute pulmonary embolism without an absolute contraindication, anticoagulation should be initiated to reduce recurrent venous thromboembolism and death. In category C1 and E1 requiring initial parenteral therapy, low molecular weight heparin is recommended over unfractionated heparin. And in patients eligible for oral anticoagulation, directly acting oral anticoagulants is recommended over vitamin K antagonist unless contraindicated to prevent recurrent venous thromboembolism to reduce major bleeding. These are like level 1 evidence. And if a patient is undergoing catheter-directed thrombolysis, concurrent low molecular weight heparin and unfractionated heparin anticoagulation is recommended over no anticoagulation. And after a procedure is performed, thrombolytic therapy is performed, initial parenteral anticoagulation with low molecular weight heparin is preferred over unfractionated heparin. So in special population, like if the patient is obese with BMI of more than 30, directly acting oral anticoagulants over vitamin K antagonist is preferred unless contraindicated. And if patient has antiphospholipid syndrome, vitamin K antagonist is recommended over DAOC. And pregnant patient, low molecular weight or unfractionated heparin is recommended. Directly acting oral anticoagulants and warfarin are potentially harmful. And in breastfeeding patients, low molecular weight and unfractionated heparin or warfarin is recommended over direct acting oral anticoagulants to prevent bleeding in infant. So like I said, monitoring of anticoagulation, it is usually not necessary. Now coming to the most important thing, that is supporting the failing right ventricle. So for us, like the most important thing, like if we are trying to intubate a patient who has presented with shock, what happens is this patient is kept afloat or surviving or maintaining the pressures because of the compensatory sympathetic surge. So if we give any kind of sedation to intubate, to tube the patient, then the RV that is already failing will absolutely fail and the patient will drop significantly and the patient can crash anytime. Also the positive pressure ventilation, it reduces the RV preload and increases the RV afterload simultaneously. That is why whenever we are about to intubate this patient, we have to be ready with all the ionotropes and vasopressors, and sometimes VA ECMO should also be available before we try to intubate the patient, because this patient can rapidly crash and we will not be able to do anything. So rapid availability of rescue cardiopulmonary bypass in 2 studies have shown to improve hospital mortality in this kind of patients. So coming to mechanical circulatory support and IVC filters, it has like level 1 evidence in known suspected case. VA ECMO has level 1 evidence in known or suspected case of pulmonary embolism and continuation of systemic anticoagulation is recommended in absence of bleeding. But inferior vena cava filter in a patient who cannot tolerate anticoagulation, but in whom a filter is deemed necessary, but the filter once put should be retrieved once the problem is solved. So coming to advanced therapies, there are various advanced therapies that can be instituted, like systemic thrombolysis, catheter-directed thrombolysis, mechanical thrombectomy and surgical embolectomy, but they are only category 2B recommendation for patients with category from C3 to E2. From A to C1 it is not recommended. So systemic thrombolysis, the FDA approved agent for pulmonary embolism for thrombolysis is streptokinase, urokinase or alteplase. They are first generation agent and not used in contemporary practice because they have long infusion time and have limited availability. But the absolute contraindications for these are any prior intracranial hemorrhage, any known malignant intracranial neoplasm, suspected aortic dissection, recent surgery encroaching on the spinal canal or brain, any known structural intracranial cerebrovascular disease, ischemic stroke within 3 months, any active bleeding or bleeding diastasis, recent significant closed head or facial trauma or brain injury. So the few catheter-directed therapies that are available are catheter-directed thrombolysis, which is taken up for category E1 and category D1, D2. For A1 to C2, it is not recommended, and mechanical thrombectomy, it is also not recommended for A1 and C2. It is only recommended for category D and E. So coming to the spectrum of clinical syndromes after the pulmonary embolism, there could either be complete resolution, there could be residual pulmonary vascular obstruction, or patient can eventually progress to chronic thromboembolic pulmonary disease with or without pulmonary hypertension. So if the patient persists and presents with chronic thromboembolic pulmonary disease, then we'll have to evaluate them at 3 months after acute pulmonary embolism. And the lung perfusion imaging VQ mismatch, the imaging is assessed for VQ mismatch along with transthoracic echocardiography. If the lung perfusion imaging is normal, then it is sufficient to exclude CT-EPD. If it is, the negative predictive value is almost 100%, and alternate therapies of dyspnea should be assessed. And if there is mismatch, then we'll have to assess more for CT-EPD and treat accordingly. Thank you.